didn't want to do a video talking about medical stuff, about coronavirus, but this is basically in response to all the craziness that is going on. I don't know, I have no idea how to treat coronavirus. Nobody does. But yeah, it's just the craziness that I'm seeing is just like crazy. Everybody's thinking they're experts, and I'm not an expert. I can tell you that from the beginning. But everybody's an expert, including people who are just like reading about certain medication, Diamox or whatever, and finding out, oh yeah, they're advising the doctors and the CDC to look into Diamox because some guy came up with an idea. It's really it's showing me how it's laughable for me because I can't believe it. It's like it just confirmed the suspicion that I have is that most intensivists in the United States don't know what they're doing. They really they have no idea what they're doing. They're doing intensive care, just out of the goodness of their heart as a secondary specialty or something like this. It's just I and I'm not, I again as I said I have nothing to do with the treatment. I can't advise you on the treatment or anything because I don't know. I'm not a researcher or anything, but I just wanted to just respond to certain things that just makes my mind blow. I was just listening to somebody yesterday, and the guy's saying the doctor. It's so excitable. He's like, I don't know how old he is. It must be like 20 or something. I'd be surprised if he's like 21. He's so excitable. It's like, wow. There was somebody in the ER. There were two patients in the ER. One of them with both with coronavirus. One of them had saturation of 54%, and he was talking to me, and he didn't feel anything bad. So we put him on high flow laser cannula, and his saturation came up. So it must be a disease that requires oxygen. It's an oxygen disease. It's not a vent disease. It is an oxygen disease that requires oxygen more than vent. And then people take that and come and ask me all the time, do you think it's oxygen, not it's like, come on. And then the same person is saying, and then next door to him, there was a patient also with coronavirus. His saturation was not bad. It was like, in the 80s on room air, and, give him some oxygen and he was fine. But he was looking so bad. He was looking so toxic, completely different than the other one. That was happy, like a clam. I was gonna say, check. Did you check your pulse oximeter? I mean, what is this? They make videos and talk about it. It's amazing. I'm just putting this out there as a response because people are just taking this and actually flying with it because somebody put a video on YouTube like myself. It must be an expert, right? The guy's like, oh, wow, it requires oxygen. It's an oxygen disease. Oh my God, it's just unbelievable. And then the same person or another person, he was saying, I mean, obviously, we all kidding aside, pulse oximeter is not accurate below 70%. So once you start saying 58, 54, 53%, I know you know shit about pulse oximeter. You know nothing about pulse oximeter. And people even shouldn't be talking to you, right? Below 70% is enough. Pulse oximeter was tested on healthy volunteers. They held their breath until the least one of them went down to 70%. So you can't just say, oh, it's it's 58 or 53, whatever. It's ridiculous, right? The other thing, people also say, one of the other guys was saying, I was laughing. I'm sorry, I can't hold myself. The other guy is like very, very excited and saying, it seems to me that this is a disease that's not requiring high pressures on the vent. This disease is requiring to fill the alveoli with as much oxygen as we can. I, As opposed to what? Well, if somebody's hypoxic, if somebody's not hypoxic, then we don't need you. We don't need the intensivist. They go away. You just leave anybody to give them nasal cannula, and they'll be fine. But if somebody's hypoxic, you need to fill the alveoli. That's maybe news to you with as much oxygen as you can. Whether you do that by raising the FiO2, you know, or you do that by giving PEEP, increasing the mean airway pressure, changing modes, anything, giving NEBS, giving Lasix, all of those interventions aim for one thing: increase the P alveolar O2, increasing the oxygen in the alveoli as much as you can. I, it's like oh my God. And then people come to me and say, "Did you hear? Yeah, what did I hear? It's an oxygen disease. It's not a real ARDS. It is just oxygen disease. The tissues are deprived of oxygen. Why? Because there's a lot of ferritin, and because there's a lot of ferritin, there must be that the oxygen is attached to the hemoglobin, or the virus is attached to the hemoglobin and preventing the oxygen, blah blah blah. So the oxygen stores, the hemoglobin stores and the iron stores and all of this bullshit. Come on, guys, come on. How many diseases we know, and how many acute inflammatory processes, and how many viral infections and bacterial infections that has high ferritin and very high ferritin. So don't try to make it that this is like that disease particularly. I'm okay putting the ferritin as part of the manifestation, because that's how we do medicine. Manifestations. You have 14 manifestation. You have 5 out of the 14. The chances are your chances get higher. You have 10 out of the 14. The chances, is higher suspicion of COVID-19. But we can't just say, oh, one single thing. Oh my God, yes, ferritin. Ferritin is an acute phase reactant. Everything has a high ferritin. But we don't just measure. We don't measure it. That's the problem. So, and people say, oh, the compliance is fine. I heard that a million times from intensivists. They say, did you hear in Italy or whatever? They didn't say that in Italy, but they misunderstand. They say, the compliance is fine. It's an oxygenation problem. So I don't know if it is an oxygenation problem. We should see like a pristine lung. We should see a normal lung on the X-ray, like a PE, for example, normal lung X-ray. But it's an oxygenation problem. The PE patient have normal lungs, and they have an oxygenation problem because the oxygen is not transferred from the lung to the arteries. Uh, Here, it's not the case. What are we seeing there? I don't know. What am I seeing on the CAT scan? Every single one of them has a huge amount of infiltrates and interstitial process on the CAT scan and on the chest X-ray. In fact, it's not only the only one. This is part of the manifestation of the disease. So don't tell me it's an oxygenation problem and don't worry about the compliance. The compliance is shit. The compliance is shit. It's horrible. There could be some other things, there could be, yes, I agree, maybe the virus attached to hemoglobin and cause some sort of hemoglobinopathy and all of these things, but don't shit on me and come and say it is only oxygenation problem. It is not a vent problem or compliance problem. Okay, show me how you're gonna ventilate this patient. And that's the other thing I want to talk about. Oh, this disease, the prone positioning, is this disease, and the public loves that. Wow, the coronavirus patients, that mysterious enemy that the coronavirus patients, they all on their faces. You go to the ICU, they're gonna be on their faces. That's the only way to treat the coronavirus. Unbelievable. Wow, how ironic. Did we ever Mr. and Mrs. Intensivist? Uh, did we ever learn about prone positioning in another disease? Maybe just think about it. Did we learn about prone positioning? Did we do prone positioning for anything else? Because last time I checked, prone position is a standard of care of treatment of ARDS, period. Any type of ARDS, viral, corona, influenza, pneumonia, anything. Pelvic fracture causing ARDS, prone position is a standard of care. So it's crazy. It's like as if it's something new. The other day in the news, Mass General Hospital is the first hospital in the country that uses nitric oxide for the treatment of coronavirus. Mass General is the hospital where nitric oxide have been invented, has been invented in Mass General. They love nitric oxide, and rightfully so. It's a great medication, and it's been used for ARDS over there before any other hospital used it for ARDS. And before the coronavirus and after the coronavirus, they will continue to use nitric oxide. It's a great medication for ARDS and for corona and for everything else. And everybody knows it, and everybody who has nitric oxide in the hospital, they use it. Right? And by the way, just as a advice, if you're in a hospital that doesn't have nitric oxide, it's so expensive, $2,800 to $5,000 per day. Right? You don't have to use nitric oxide. Use nitroglycerin, inhaled nitroglycerin. Inhaled nitroglycerin will give you an immediate improvement in oxygenation, similar exactly to nitric oxide. Doesn't drop the blood pressure or anything. Basically, the protocol is to take 200 mics per cc nitroglycerin, put 20 cc's in a big nebulizer that takes 20 cc's just to give you some time, and attach it to the vent and run the wall flow meter at 6 liters per minute. That means the 20 cc's nebulizer will nebulize over and finish over 2 hours. And you'll see the effect right away. If it's not gonna cause any, if it's not beneficial, you'll see it. It's not gonna be beneficial. But you're not gonna miss it. The results could be amazing, like nitric oxide. But it's $2 the whole day. The other one is $2,800 to $5,000 per day. So it makes sense to use the inhaled nitroglycerin. That dose, by the way, will result in about 30 mics per minute, which is a typical starting dose for nitroglycerin IV anyway, and it doesn't drop the blood pressure. And again, it's a trial. Use it. It will improve because by definition, the nitroglycerin work by forming nitric oxide. So the same thing. The only difference is that it's nebulized, so it's going to disperse a little bit. We'll talk about that in a second. And number two, the dose is not accurate like the nitric oxide dose, but so what? Nitric oxide is titratable anyway. There's no like a single like magical dose. You titrate it up and down. And after all of this discussion, nitric oxide has not ever been shown to have mortality benefit. So it improves hypoxia, but no mortality benefit. So if you're one of those study hawks that love mortality studies, there's no mortality benefit from nitric oxide. So it's not worth spending $5,000 on it. But anyway, if you have it, God bless you. Just use it. God bless your patients. It's a great drug. Just watch for methemoglobinemia, and don't deplete the hospital cost-wise. In any case, that brings me to something else. In the beginning of the epidemic, thanks to the CDC, we did not use. I did not use nitroglycerin because it's a nib, and we're going to disperse the droplets. Now with the Brockton COVID-19 tent, when we make a tent around the patient with plastic and that kind of control the droplets a little bit, we can use inhaled nitroglycerin now. So it should be some of the things in your armamentarium. The other thing that it makes me go crazy is the prone positioning. We talked about the prone positioning and how it's a standard of care and everything, but people are going crazy because people hear something and they just get, they're grasping at things because there's no treatment. So, they read, okay, prone position, they prone everybody. You know, I heard about a hospital that has 12 patients prone. 12 patients prone in a single ICU. How much manpower required to do this? I mean, can you use this manpower to take care of other patients? We said that we don't have enough staff and all of this thing. We're hiring people without licenses to work, and you're wasting the staff doing prone position on 12 patients. I can never find 12 patients in my ICU requiring prone position, and it's really amazing. But it brings me to another point. The mode of ventilation. Enough, enough, people, enough sticking to the volume control. Enough. This is a mode of ventilation. This is the first mode of ventilation ever invented, and it's the only mode of ventilation that the mode that is used the most in the world. 85% of vents in the world are volume controlled ventilation. The study that was published about volume control and low tidal volume is 22 years old. I know it became the standard of care since that time, low tidal volume ventilation, volume control, but it's 22 years old. Is it time to move on or not? It's crazy. We gotta move on. We've got to move on. Ironically, the study that showed that APRV is better than low tidal volume volume control ventilation in the ventilation of ARDS patients. This study was amazing. The numbers of the study are almost unbelievable. There's like days on the vent, average 19, I think, for the volume control versus 3 for APRV. Mortality was also like very, very high, like half the mortality for ARDS, for APRV on ARDS on APRV versus ARDS on the low tidal volume. And by the way, the number of mortality and low tidal volume ventilation in that study was 30%. And I'll get to that in a second. Right? Just remember that number. The other number was 15% for APRV. Less trachs, improved oxygenation, decrease even mean airway pressure on APRV compared to volume control. It is, and people, and all of them are statistically significant, except mortality. Mortality, they halved the mortality with APRV, but the p-value came out to be 0.053. So everything else improved. They leave the ICU early, less trachs, improved FiO2, improved compliance, less actually pressors, if I remember right, and less days on the vent, and a huge trend towards improvement in mortality, but just didn't meet statistical significance. You tell that to people, intensivists, and they say, "Oh no, we're not applying APRV. There's no mortality benefit." And you want to pull your hair. You want to pull your hair for the points, and then the laughable thing when people say, "Well, the ironic thing is that the study comes from China. 2 years before this epidemic, the study was published. It has nothing to do, obviously, with the epidemic, but I'm just saying that study ironically comes from China. And people, before the epidemic, when you present the study to them, you see people saying the Chinese falsified the data. The Chinese lied. Because it's China, they must have lied in the study. Well, how do I tell that you didn't lie in your study? Does anybody review the study? Review what you've done, your work? Nobody. That's a topic for another discussion. Nobody. Evidence-based medicine. Just send it to New England Journal of Medicine. Have the right hospital next to your name and the right qualification, and it will be published. So nobody knows who lied and who doesn't lie. And I laughed at these people and told them, so if the Chinese lied, why didn't they lie in the mortality? They could have lied about the mortality, made it more significantly, statistically significant, and they left the other ones, maybe days on event or whatever compliance is not is not statistically significant, whatever. But you just can't say they lied because they didn't. It doesn't look like they lied, not more than anybody else could have lied in their study. So we have a study, if you like studies, and we have physiology. You have physiology, right? The physiology is compelling for APRV. You're limiting the high pressure, so you're not injuring the lung. And we learned from Dr. D'Amato's study and Esteban's study and all this that the pressure is more important. The plateau pressure is more important than the volume itself. And number two, we learned that the most famous study, the ARDS-NET trial that came up with the low tidal volume ventilation, this study is comparing volume control versus volume control. It's a scam. Or the way we understood it is a scam. It's volume control versus volume control. Okay, so if you're a user of volume control, use low tidal volume. Okay, that's it, done. If you're a user of any other mode of ventilation, if you evolved like you're supposed to evolve and move to another mode of ventilation, you don't have a study yet. Wait for your study. But but and that's what makes this study from China very important, because it actually one of the first studies that actually compared volume control to APRV in a randomized control trial and showed huge benefit. But the physiology is compelling. When you're not, so the pressure is limited, but the time is long, and the volume is dependent. So I'm not gonna go. If you wanna talk, learn about APRV, I have like 7 videos or something, or 8 videos you can learn about. But we're not teaching the mode. What we're saying, just for the general public, is basically if you have instead of opening the lung with the volume, or the pressure and injuring the lung, you're opening the lung with the time, by neither volume or pressure, right? By the time, or at least by the pressure time integral. So imagine if you put, when you actually get the popcorn, and you put the popcorn in the microwave and press popcorn. Do all the corn pop at the same time? Of course not. They pop at different times. That's exactly the alveoli in the lung. The first one that opens is the healthiest, and the last one that opens or pop is the sickest alveolus. And that's why, by just going time, long time, you're opening all the alveoli. And that by itself improves everything. As we always say, bacteria doesn't like to fly, it likes to swim. So if there's a puddle of water in the alveoli, puddle of fluid, bacteria sits in there. Number two, huh? If you leave the alveoli closed and open them every breath, that's called atelectrauma. That increases cytokine, increases inflammation, and patients do worse. If you're opening it all the time, and you're just moving it from the open to more open position, and that's APRV, that's probably less inflammation, right? So anybody who uses APRV will have that experience. We don't need to prone that much. We're not debunking saying that you shouldn't prone. I prone. Everybody that I know that uses APRV prone people, but we're not crazy. You should not be crazy. You should use the mode to your advantage. If you put the patient on APRV and the patient has great PF ratio and great oxygenation on it, what's wrong with that? What's wrong with that? Don't prone the patient. Complication and uncertainty and manpower in an epidemic like this. I'm telling you, this epidemic showed me how inflexible our doctors are in the ICU, especially intensivists. How inflexible we are. We are completely inflexible. For an intensivist to prone half his ICU, huh? It tells me that he's not even involved in the proning process. He's not involved. Cannot be involved in the proning process. Although the intensivist should be involved in the proning process because it's dangerous, right? It tells me that he's not involved, or she's not involved. If you want to prone a patient, you sit next to that patient and actually help with every single aspect of proning, and that will show you that you cannot prone half the ICU. And it's not like a magic bullet. It's not like okay, somebody's proning to so much. Why am I so? They have the resources, okay. That's not what I'm saying. What I'm saying is that it's not a magic bullet. It's not, and don't try to impose it on people because some people don't have the resources and they'll be looking, saying if we had prone this patient, what something would happen. It's not a magic bullet. You prone the patient, and sometimes they improve, sometimes they don't improve, sometimes they improve and stop improving or whatever. It's not a magic bullet like he's gonna run out of the ICU immediately after you prone him, right? So stuff like that, and then you hear people. The prone position, as everybody knows, like there is a protocol. It's 5 days, 16 hours on your face, and 8 hours on your back. That's the protocol. I mean, it could be a different protocol, but that's the protocol that we do. It came from the study. And you start hearing, oh, we're gonna probe patients when they're not on the vent and stuff like that. I don't want to have a strong opinion about that particular thing, but it's not gonna help. I mean, the help of that is no different than doing chest PT. So nobody's gonna stay on their face for 16 hours. Nobody's gonna stay on his face with the respiratory failure like this for more than an hour or two at the most. That's fine. If you feel that you want to put the patient on their face for an hour, maybe mobilize some secretions or something, that's fine. But I don't think it's that helpful, and we should be like, oh my God, you know. Uh, and then the other thing, this high altitude thing. Oh my God, it's just this is funny. It's like the lung is filling up with fluid, so and somebody came out and made a video and it's like, wow. I looked up a high altitude. It's the same symptoms as COVID-19. What is it? Hypoxia, dizziness, and the lung is full of fluid. Really? There's all of them. All of them are the same. And then the people was coming and said, "Oh my God, we've never seen a disease like this before. Uh, we we feel very bad, and blah 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 blah." And cry, and nurses that cry on TV is like, oh my God, oh my God, just to wanna be rich and famous, you know. Have you seen that nurse? It's unbelievable. It's crying on TV, and then you interview her on TV. She's like a drama queen. But anyway, um, why are you crying, man? If your job makes you cry, just don't. Please go home, go home, and look for another career. I'm not talking about somebody who maybe cries in confidence or something. Just go and maybe tear up because of the he lost a patient or something like this. Yeah, absolutely, we all do that. But just go and make a huge video crying, sobbing on the video so everybody in the world can see it. Come on, just go find your acting career or something like this. But anyway, and they start crying, and we've never seen disease like this. We feel our hands are tied. We can't treat anything, because there's no treatment for it. Oh my God, we feel that we don't understand the disease and there is no treatment for it. Okay, what's the treatment for ARDS? Nothing. What did you do for ARDS? What, it's not the treatment you don't know for ARDS. You're not even interested in changing your vent mode, right? You're too proud to change your vent mode for ARDS patients, huh? You're lazy. You don't want to do any of the interventions that can potentially help patients with ARDS. And every time we speak to you and say, do this and do that, you say there's no mortality benefit. There's no evidence, right? And then when it comes to this, and you say, oh, we don't have it. It's like ARDS. Regular ARDS has nothing to do with the coronavirus. Any ARDS, you don't have a treatment for it. In fact, ironic and pathetic enough, ARDS has a 30% mortality rate since 1950s. And after application of the low tidal volume ventilation, that's why I told you keep that in mind when I told you about the coronavirus Um, Sorry, when I told you about the Chinese study about the APRV versus volume control for ARDS, they also had 30% mortality rate. Mortality rate in 1950 was 30%, and mortality rate in 2020 from ARDS is 30%. Nothing changed. All of this advances, we still have 30% mortality rate. So don't give me this bullshit about the disease that I don't know the treatment for. Many diseases that we treat, we don't know if anything changes after this epidemic, I think intensivists need to have much more robust studies. I hope this epidemic will make intensive care, a hot spot like cardiology, and studies are going to start to flourish and being probably supported or paid for by institutions and NIH and stuff like that. That's the only benefit that we will get from this epidemic, because I can see there's a lot of things that are basically old researchers that are not big enough on successful, but not big enough on obscure drugs and obscure interventions for ARDS. They are the ones that are now kind of resurrected again, trying to be to be a treatment for coronavirus. Mm? So that's why I was saying, that's a big, huge benefit from this. If there is a silver lining, that will be the silver lining. A lot of drugs that were supposed to be developed, like the remdesivir, for example, that was supposed to be developed for SARS, which is another coronavirus, and was developed, but then the company, it's a private company. Why would they go and develop this and pay millions and millions of dollars where they can roll in Harvoni and make tons of money regarding treating patients with hepatitis C? So they put that on the shelf. The government should have jumped on this and said, this is a national security issue. We are developing the drugs, or we're helping you, or whatever it is to develop the drug. That we would have had, that. That could be a treatment. As for the hydroxychloroquine, oh my God, that's a disaster. That's a farce. Azithro, both of them, Azithro and hydroxychloroquine, are anti-inflammatory. That's why they is given. And then of course, the steroid business. Oh my God, how many people? I mean, how many people probably did not make it because the intensivists don't know the material very well. When somebody says no steroids for coronavirus, what they mean is what? No steroids for when the guy shows up in your office, in your goddamn office, don't give him steroids. But when the patient shows up in your ICU on the brink of death, and he has cytokine storm, and all the organs are developing what looks like SIRS picture or cytokine storm picture, steroids are indicated there to bring their hyperimmunity to EU immunity, to normal immunity level if you can. How many people did not receive steroids because of the fear, the unfounded fear of don't give steroids, because we're having people are just coming up with things. There's big institutions that came up and said, we come against the cohorting of patients on COVID-19 patients on 4 patients on a vent, or 2 patients on 1 vent, or something like this. People, they live in bubble. These people who came up with these institutions that came up with this recommendation, they live in a bubble. They don't live in real life, because nobody's gonna wake up in the morning and say, oh, you know what? I feel like putting room 4 and room 7 together on a vent, just for fun. Just let's put them on a vent because I feel like doing that today. Nobody's gonna do that. People are gonna be doing that, or doctors have to be doing that, and it's so difficult to do, right? They're gonna be doing that because the alternative is death. Either this patient is gonna die, I'm not gonna give him a vent, or I'm gonna cohort the patients. Don't tell me that we came against it. Came against it what? That's pathetic. You came against it because you should have taken a different position. Your position should be, we recommend it to leave it as a last ditch effort, but this is the way to do it. That's what you are assigned or paid for, if you will. If you're getting paid, you shouldn't get paid. Mm? That's what you're in this position to the leadership position to say is that after talking to experts, this is the way to do it. Cohorting is not a good idea. We don't recommend it unless it's blah 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 blah, and all the disclaimers. But when you do it, that's the way to do it, to at least minimize the injury. And by the way, for anybody who, if we ever reach that level, hopefully never, but if we ever reach that level, don't use volume control. You're gonna kill the other patient. If somebody coughs or somebody's being suctioned, the other guy is gonna get the rest of the 1500 total volume and pop his lung. The best thing is pressure control. Pressure control, you can ventilate a neonate and a 400 pounder. The peak airway pressure for both of them or plateau pressure is 30, both of them. And everybody's gonna get his appropriate tidal volume or corresponding tidal volume based on their compliance. So I don't know. I feel like I talked for too long, but I just had to respond to this. It's like it's crazy. This disease, I don't think it's a lot different than any other disease. It's just there's a lot of them coming at the same time. That's why we're overwhelmed. But as an ARDS from a certain infection or virus or pneumonia, it's like any other. Maybe some subtle differences. We'll see that. There's some pathologic studies showing some microthrombosis. Although I'm suspicious that microthrombosis also can happen in other, or actually is part of the pathogenesis of other lung inflammation and infection. So it's not very unique to it, but we'll give it the benefit of the doubt. But the picture that we're seeing, interstitial infiltrates like ARDS, if you put them on the volume control and 5 of PEEP, you will be calling for stat prone positions all the time. If you put them on a APRV or bi-level, you are not going to be needing as much volume control. You can use inhaled nitroglycerin. Put the patient on a tent if you're not intubated. Think outside the box. We're killing their kidneys, so don't kill their kidneys. Make them dry, but not that dry, because we end up killing their kidneys and they fail from another aspect. And then, of course, this is another topic for a long discussion. Be my guest. You're an ideologue. You're a bicarbophobe. Keep being bicarbophobe. Don't give your patients bicarb, and show me how you're gonna extubate those patients. Just one last thing. If you are a patient with, if you have a patient who's like 30 years old with coronavirus that damaged his lungs completely, this is, you suddenly you became as bad for a lung as somebody who had COPD for all his life. Both lungs are unable to change CO2 and oxygen. Okay? Whatever the mechanism is, but both lungs are as crippled. If you have a scale on a crippleness, you're 10. Both of you are horrible lungs. But the COPD had horrible lungs over 40 years, been developing that. And his kidney or her kidney is developing bicarb, raising the bicarb to allow the patient to decrease the CO2 only to 60 and live with that. If you insist on a coronavirus patient or any ARDS patient for that matter to maintain a PCO2 of 24, bicarb of 24, you're never going to be able to extubate the patients because you're asking them to breathe or reach to the level of breathing and efficient CO2 exchange as if they didn't have the injury. It will never happen. You have to raise their bicarb so they don't have to breathe all the way down to 40 PCO2. They can just breathe to 50 or 60 and have a normal gas and live like that, right? This disease is no different. The only difference is actually, in my opinion, a boring difference. When we get patients with ARDS, we are used to patients with ARDS combined with shock. These people are not combined with shock. They're just very, very hypoxic and very hypercarbic and increased work of breathing. So so we don't give them a lot of fluids and we start even diuresing them. So what end up happening is that the regular ARDS have a lot of fluid on board. They are very, very wet. and they develop their ARDS is really much more difficult and much more lethal in the first day or two. And we spend so much time doing different things and proning and this and that, and all kind of hypoxia algorithm, if you will, in the first day. But then after that, once you start dialyzing them, they start diuresing them, whatever, then they start improving and improving quickly. So that's more gratifying. You spend a lot of time sleepless 2 nights maybe, and then for the COVID-19 patients, it's kind of more boring because they are just badly hypoxic. You can do SBTs all day long, SPTs, whatever you want to do, and they are just tachypnic to the up to wazoo and hypoxic, and you put them back on the vent, and you do SBT again, you put them back on the vent, and you're just not getting better. They're just taking a long time to get better. So it's just more lingering and annoying a little bit. And because they stay on the vent for a long time, the vents are depleted, and if there's a surge, it's going to be a problem. Um, I hope this helps. I could be wrong, obviously, uh, in one or two things that I've said, or all the things that I've said, but I don't think so.